Hi everyone. So in this lecture, we're going to talk about the different types of heart failure, and then we'll also discuss cardiomyopathies, which are really diseases of the heart muscle. And so these can lead to heart failure, and we'll talk about them at the end of this lecture. So one of the first things we need to understand in terms of the overall basics of heart failure is that you have a reduced cardiac output. Okay, so let me get my pen here. All right, so one theme we're going to see is that there's a reduced cardiac output, and that is for all types of heart failure. There's a reduction in the cardiac output, and there is a backup of venous pressure. And that logically makes sense if you think of the heart as a pump. If the pump fails, that means fluid backs up, right? Because it can't get through the pump, and there's nothing getting pumped out necessarily. So the cardiac output would go down. And that's obviously an extreme where there's absolutely no cardiac output, but there's degrees of failure in which the cardiac output would be could be somewhat compromised, okay, to various levels. Just as a reminder, in terms of cardiac output, okay, this is the amount of blood that's ejected by each ventricle in a minute, okay. That equals the heart rate times the stroke volume, okay. At rest, normally in an adult, it's somewhere between 4 to 6 liters per minute at rest, all right. Varies with the size of the person, of course. And then we have something called a cardiac reserve, and that's the difference between the person's maximum and the resting cardiac output. Okay, so for example, somebody who's very, very fit, their cardiac output during maximal exercise could be somewhere in the order of 35 liters per minute, and at rest, 5 liters per minute. Okay, somebody who has very little cardiac reserve wouldn't be able to get their cardiac output to rise much above rest. So an example, 5 liters per minute. When they're trying to exert themselves, it may only go up to 6, 7, or 8 liters per minute, which would severely compromise their ability to exert themselves. So again, the overall basics of heart failure is that you have a buildup of or a backup of blood flow or venous return. You have a reduced cardiac output, okay? And you could also have a problem with the cardiac muscle itself, okay? So the pump itself could be the problem, in which case you have a decreased cardiac output and a backup of venous blood. You could have an increase in the afterload. The afterload meaning something like high blood pressure, for example. Somebody could suddenly have a spike in their blood pressure that's so high that the heart can't overcome it, and that could send it into a reduced cardiac output and a heart failure type picture. You could have somebody who has aortic stenosis. So the valve doesn't open up readily, increasing the afterload on the heart, and the heart fails because of that. You could have volume overload. Someone who's got an excessive volume, which is overloading the heart and causing the pump to fail. Or you could have a problem with the muscle itself, like in the cardiomyopathies, for example. You could have an ischemic cardiomyopathy where there's coronary artery disease and damage to a section of the ventricular wall, causing it to not pump as effectively. Or it could be a viral infection and so on. Okay, so let's talk about stroke volume. Recall that, again, stroke volume times heart rate equals your cardiac output. So we're looking at just the stroke volume, and this is something we have discussed previously in physiology. But let's take a look at our graph over here. So here's stroke volume, all right, in milliliters, and then ventricular and diastolic volume. All right, this can also be looked at as the preload. The preload, or the volume with which the ventricle fills up with right before it's about to contract. Okay, that's the end diastolic volume. And so here's our control. So this would be, say, our normal or baseline. Okay, and it has this curve, which you see here in green. So here's this curve here. And what we've picked out over here is this normal resting value, meaning that if our end diastolic volume is, say, around 120 or 130 milliliters, okay, typically at rest, the stroke volume that's associated with that is going to be somewhere over here, right? And that's going to be probably about 60 or 70 mils. Okay, so that's going to be the stroke volume. And if we increase venous return, all right, if we increase venous return, we would go up this way on the curve because we are increasing our preload, and we'd end up with a larger stroke volume. If we decrease venous return, we'd go this way down the curve because we're decreasing our preload or our end diastolic volume. So therefore, the stroke volume would go down accordingly. The orange line over here represents an increase in contractility or an inotropic state, and that's induced from sympathetic stimulation. Right? So for example, for exercising, our sympathetics go up, it increases our heart rate and its contractility. So now we're actually getting, for any preload, for any volume, an increase in contraction. So if we start off with what our normal amount is here, let's say 120 mils, if we're in a sympathetic state where there's an increase in sympathetic output, we'd have increased contractility. So for the same volume, we'd get a harder contraction and our stroke volume would thus go up because we're injecting more volume. Okay, so hopefully this is all review from physiology. Okay, but keeping in mind that the three factors that affect stroke volume are the preload. So if I increase preload, I'll increase the stroke volume. Contractility. If I increase contractility, I can increase the stroke volume. And afterload. All right. If I increase afterload, I decrease the stroke volume because the afterload is the force with which it has to overcome. So if there's an increase in hypertension or blood pressure, or if there's aortic stenosis, that's something the ventricle has to overcome, and it prevents it from being able to eject blood effectively. Okay. So I gave some examples over here, which you guys can take a look at. But this is an important relationship because in heart failure, you're going to see a decrease in stroke volume. And these factors right here, preload, contractility, and afterload, all play a role in the heart failure picture. It could either be due to any one of them or a combination of them, which of course would affect our cardiac output ultimately because that's composed of stroke volume and heart rate. So this is looking at this again, stroke volume versus end diastolic volume. Just so you guys understand, sometimes they'll put it like this, will be left ventricular end diastolic pressure, or LVEDP. Okay. In many cases, this is interchangeable with the volume because as the volume goes up, it creates a certain amount of pressure inside the chamber. And that pressure that's generated with the volume is dependent on the compliance of that chamber. So when we say, for example, the LVEDP, or the left ventricular end diastolic pressure, is going up, that really, in most cases, is reflecting an increase in the volume. Okay, so it's essentially the same thing we're looking at here. So again, our stroke volume, our pressure, or our end diastolic volume, and this is, let's say, our working point right here. And I talked about the venous return, how that affects that. And then the same thing over here. If this is our working point, if we have a decrease in afterload, we would go up onto this curve right here, where for a given volume, we would actually increase our stroke volume if we reduce the afterload, right? So we can actually eject more because there's less resistance to it. And then over here, if there's an increase in the afterload, that would actually hinder our ability to eject volume, so the stroke volume would thus go down. Okay. Now, these same lines, it could be increased afterload or a decrease in contractility. Decreasing contractility, I just put contraction there, but you understand. And then over here, this would be an increase in contractility. All right. So those are associated in that regard. Okay, so let's take a look at this now. Let's put this in sort of a clinical picture. So here's our stroke volume. All right, so the stroke volume over here. You'll also notice it also says in parentheses or cardiac output. Understanding the relationship with stroke volume and cardiac output. And then we have our normal curve right here in the center. Okay, and our point A, which is our starting point. Okay, that's our normal. And then you'll see that we have another line for increased contractility over here, which would be due to, say, something like sympathetic activity, for example. And then this line down here, which really represents essentially all forms of heart failure. Okay, because you got to keep in mind that all forms of heart failure, regardless of the type, will have a decrease in their cardiac output. Okay, and it's usually secondary to a decrease in the stroke volume. So, a couple other points I want to make about this graph is you'll notice on the extreme end down here on the x-axis, all right? Well, first off, the x-axis is showing you our end diastolic volume, or our preload, all right? Or our left ventricular end diastolic pressure, which I talked about in the previous slide and how they're related. And you'll notice at the extreme over here we have pulmonary congestion. The way to interpret this is that if the volume here goes too high, again, volume is increasing in this direction. If it goes too high and we're in this zone over here, that zone, the volume might be high enough to cause fluid to back up into the lungs and cause congestion. Over here with the stroke volume and cardiac output, you'll notice a little box for hypotension. Basically meaning if the cardiac output drops, or the stroke volume drops enough, that can affect ultimately blood pressure and produce hypotension. Okay, keeping in mind that the equation for blood pressure, arterial blood pressure, is equal to the cardiac output, times the total peripheral resistance. So that's our blood pressure equation. So here's how cardiac output factors into that. So cardiac output goes down because of heart failure, we can become hypotensive. So if we take a look here at our normal curve, we're starting at 0.8, that's our normal, point A, excuse me. And let's say there was some sort of ischemic episode, okay? The person had coronary artery disease and they suddenly went into heart failure. So we're going to drop to point B, okay? So point B is showing you an acute change in the function of the heart. And so we're now down in this line here. And so this line would really represent overall kind of a decrease in contractility, if you will, or some other factor that's contributing to a drop in our cardiac output, okay? Something you should notice though, when it drops, you'll notice that of course the stroke volume is going to drop. That's going to affect the cardiac output, so the cardiac output would drop. That would also affect our blood pressure, and we're awfully close to hypotensive. In some cases, the patient may become hypotensive because the cardiac output drops significantly. But in this case, it's just on the borderline. What the heart's going to do, though, is it's going to compensate. It compensates usually within about 30 seconds due to the sympathetic nervous system. But then, there's other adjustments that'll be made, which we'll talk about. But one of the adjustments it's going to make is to move it along this line or this curve here, because now it's operating on a new curve due to this heart failure. So it has a new contractility baseline. And it's going to move towards C here. So point C. So what's happening here in point C is we've increased, because we're moving along the axis here, we're increasing the volume. Keep in mind, if you go into heart failure, cardiac output goes down, and I told you that venous return, or there's venous backup, so venous return can kind of increase. And so that's what we're seeing here is the fluid starts to accumulate in the heart. And this can actually work in our favor, especially initially, because the Starling mechanism, we back up with the fluid that stretches out the chambers, and actually puts the myocytes into an optimal position to contract even better. And so what's happening here is the volume increases to point C, we're going to get a better Starling mechanism type contraction. And you'll notice that it actually improves our stroke volume, okay? That helps to improve our stroke volume. So our cardiac output will improve. It's not back to normal in this example, but it is improved from where it was. So it's helpful in that regard. And I'll show you later on, some more compensatory mechanisms that are going to help make that even better. However, you'll notice that if I retain too much volume, say the kidneys are helping or something like that to retain volume due to this low flow status, I can end up in pulmonary congestion, right? On the other hand, if I'm not able to, keep that volume, or my contractile ability is really compromised, I might become hypotensive. So these are factors that you would see in heart failure. The pressure volume loop is really kind of useful in this scenario to understanding the different types of heart failure. Now, I've discussed this in physiology, but I'll quickly review some of the basics of it. In that, what it helps us, it takes a look at end diastolic volumes, as well as the pressures that are related to that, and helps us take a look at the stroke volume and afterload and so on. So let's go through it and see how this works. So this is our end systolic volume at this point right here. You'll notice this axis is showing pressure, okay, in millimeters of mercury. And all right, so we're looking at the left ventricular pressures. And you see here at this point, this is end systolic volume. So it's just finished systole. It's filling up with blood. As it fills up with blood, this is volume here on this axis. So it fills up with blood in this direction. So it fills up with blood passively, okay? And you'll notice that it may increase a little bit towards the end here, when we get to this point over here somewhere, you're going to see that that's now our end diastolic volume, somewhere around 120 or 130 milliliters. Okay. At which, the ventricle is going to start undergo systole. So that's this point right here as it rises vertically due to that isovolumetric contraction. Once it overcomes the afterload, okay, this point right here represents afterload. How much blood pressure has to overcome, or a stenotic valve, for example. That's when the aortic valve is going to open. It's overcome the afterload, but it continues to generate more force. Okay, so as it generates more force, we see a peak, and then that force starts to drop, and then the aortic valve closes, and we go through our isovolumetric relaxation. Now, the volume that was lost during that phase, okay, is actually measured right here by the width. Okay. And the EW just has to do with the work of the heart, which is the area in this curve, which we're not going to concern ourselves with right now. But the width of this, all right, is the stroke volume, right? Because that's the amount of volume that was lost from the time of contraction to the time it finally relaxed. So that's our stroke volume. And it gives us the end diastolic information. So this is actually very helpful too, because we can take that stroke volume, okay, and we can make a ratio out of that. We can take our stroke volume over our end diastolic volume, and that's going to equal our ejection fraction. And normally, if we take an ejection fraction as an example, you guys can calculate, say that, let's say it was 70 mils was the stroke volume, and the end diastolic volume was 130 mils. You're going to end up with somewhere around 55% or so. Okay, so that's a normal ejection fraction, anywhere between about 50 to 65%. It's a pretty wide range. So let's look at this in a little more depth now. So these are pressure volume loops, but what I want to do is I want to take preload, afterload, and contractility and look at them one at a time and how it changes. Understand that there's going to be combinations of these things going on, but let's just look at it one variable at a time. So again, our pressure volume, so here's pressure, here's volume over here. And in this case, all we're doing in A is we're changing end diastolic volume only. All right, so if 1 is our starting volume loop, all right, so 2 just means we've increased the volume to 0.2. All right, so that's our end diastolic volume here, which would be, so if 1 was the end diastolic volume is here, for 2 it's about here, okay? And it's got the same afterload. The afterload hasn't changed, which is why these points are all the same right here. There's no change in the afterload. And it's going to eject to the exact same point. In fact, they drew it in the other curves over here. I'll bring your attention to it over here for a second. The ESPVR, the end systolic pressure volume relationship. And that has actually experimentally been figured out. And it's linear, essentially. Okay, I'm just going to draw it there so you guys have it. Okay, that's our ESPVR. And it's going to go back to that exact point. Why it does that is because it reaches this point regardless of the volume it starts with, because as it ejects that volume, it can only contract to the point where it comes in equilibrium with the afterload, where it can no longer eject any further because it's in equilibrium. So it stops at that point. And it doesn't matter what the preload was. But you'll notice something though, from 1, 2, and 3, that the box or the volume loop got wider, which just means the stroke volume went up, which we already knew. We knew that again, right? That with an increase in preload, we get an increase in stroke volume. So graphically, it's just representing that. Now in B, what we have in B is we're changing the afterload, but keeping the other conditions the same. The preload's the same, contractility is the same. So here's our preload point. That's our end diastolic volume right here, okay? And here's box 1, goes to this point. So that was with the afterload at that point, okay, which is the lowest afterload of the 3 here, okay? This is 0.2's afterload, and then the afterload on 0.3. That, again, that's the pressure that has to be overcome to eject blood. And something you'll notice, we're using our ESPVR again, which was experimentally obtained. And what it means is, again, I can only contract those muscles, right, so far until I come into equilibrium with the afterload. When I'm injecting blood, I have actually more force than the afterload, so I can overcome that afterload and eject the blood. But once I come into equilibrium with the afterload, it's going to stop. I can't eject any more blood into the aorta. So what you're seeing here is with the lowest afterload, I can eject or have the largest stroke volume. Okay. If I increase the afterload, but I keep the volume, the preload the same, it's the same. What happens is you end up with a shorter stroke volume because I have more force to overcome. And then finally here at 0.3, you'll see that's the highest afterload, and you see that's the shortest width, or the smallest width there. It's the smallest stroke volume because it's the highest afterload that has to overcome, meaning it comes into equilibrium with a much higher afterload earlier on. So stroke volume goes down in that case. Okay. And that's again something we knew, but graphically that's how it's represented. And then finally, the last piece here is contractility. If I change contractility, but I keep preload and I keep afterload the same, this is what it would look like. So here's one here, and remember the preload is the same, afterload is the same. The way I depict contractility in this case is by the slope of the ESPVR. So this ESPVR, the slope of this represents our baseline contractility of our heart. Okay. If I have sympathetic stimulation, for example, so I'm activating beta-1 adrenergic receptors, I can actually increase the slope. So that's what the ESPVR2 represents, an increase in contractility. So for the same volume, same afterload, look what happens. I contract much harder for that same volume. I eject more. Therefore, the width of 2 from here to here is greater than 1, and my stroke volume is increased. Again, it makes sense. That's just what's happening graphically. And the last thing I want to point out, though, is in terms of slope, if I have a reduced contractility, which is what happens in certain forms of heart failure, the slope would be decreased. So I might have an ESPVR of a slope that's like that. That's less than. Okay. So how can I tell the different types of heart failure with that information using these flow volume loops? So here's our pressure. Here's our volume. Here's our normal loop, which you can see is labeled in black. Okay. I have to use a different color for this. All right. So here's our ESPVR, all right, of our normal. And then look what's happened over here. And I just told you on the previous slide that a change in contractility can be represented on the slope of the ESPVR. So if it was increased, if it was going in this direction, that would be an increase in contractility. The fact that it moved in this direction means there's a decrease in contractility, or in other words, a decrease in inotropy. Okay. So if that happened, let's just draw out quickly what would happen immediately from that change. Let's say it had a sudden drop in contractility, and we had the same preload, which would be right down here. I'll use a darker color here. So this is our preload right down here. Initially, what's going to happen is we're going to go, and if the afterload hasn't changed, here's the afterload. As it ejects, it's going to hit this point here early and then fall down to here. And that is a very small stroke volume. But what happens is this. If I don't eject as much stroke volume, that means more volume is left behind in the ventricle. And now I'm going to have my normal volume coming from the left atrium, which means I'm going to have even more volume on the next cardiac cycle. And that increase in volume means I'm going to have an increase in my end diastolic pressure. So the next beat around, I'm going to end up at this point right here with a higher end diastolic pressure or volume. And same afterload. But now as I hit here, what's happened though is I've slightly increased my stroke volume. So it helped to compensate somewhat. But you'll notice that the loop has actually shifted to the right. And my stroke volume, even though it's compensated, is still smaller than the normal stroke volume. The normal stroke volume is over here, from the width of this box, from here to here is my normal stroke volume. That is much greater than the compensated stroke volume you're seeing there with that reduced contractility. Okay? So we refer to this decrease in contractility, okay, as systolic dysfunction. The inability to contract effectively, to contract the muscles effectively, okay? So there can be impaired myocyte contractility, so maybe somebody had a myocardial infarction, maybe chronic mitral regurg, dilated cardiomyopathy, and so on. There's different causes for this, okay, which we'll get into some of the details on that in the cardiomyopathy lecture. Now, another term for this, we don't usually call it systolic dysfunction as much anymore. The more common term for this is heart failure with reduced EF, or sometimes written in the chart as HF, okay, with a little r and an EF. Okay, that means heart failure with a reduced ejection fraction. I just spoke about what the ejection fraction was in the previous slide. Remember, that's stroke volume over the end diastolic volume. Okay, so I show you the ratio again. If I have my stroke volume over the end diastolic volume, okay, if my stroke volume has gone down, okay, that's going to decrease my ejection fraction. But you notice that I had some increase in my end diastolic volume. I've also had an increase in my end diastolic volume because it's retaining more fluid because it's not ejecting as much. That means an increase in the denominator here plus the decrease in my stroke volume is going to result in a reduced EF, a reduced ejection fraction. Okay, so this is again systolic heart failure with a reduced EF. Just think inability to contract. Now this is a heart failure with a preserved EF. So the ejection fraction hasn't changed. However, let me write this formula in: stroke volume divided by the end diastolic volume. Okay, this stroke volume does go down. Stroke volume always goes down in heart failure. Okay, so let's just talk about this on the graph real quick to see if we can understand this. We have our pressure and we have our left ventricular volume. All right, here's our normal loop with the outline in black. And then you see the ESPVR. Now with the contractility issue, you notice that the ESPVR here had changed. It moved in this direction, okay? In this case, what we have is a diastolic dysfunction, not a systolic dysfunction. In other words, this heart is able to contract. It doesn't relax very well, okay? So it has the opposite problem. It doesn't relax, okay? But it can contract. The problem is if it doesn't relax, that usually means it's not very compliant, which means it doesn't take in blood as readily, okay? And the pressures are higher, all right? So because the pressures are higher, not as much blood can fill up those ventricles, which means it can't eject as much blood. It's a preload issue. Decrease in the preload, decrease in your stroke volume, okay? So again, that's why I say loss of ventricular compliance. And there's multiple reasons for that, which we'll get into later. But if we're talking about diastolic compliance issues, we look now at this bottom line down here, this bottom line, this filling line. This what represents end diastolic pressure volume relationship. And what it really represents is this slope of this line right here, the EDPVR, represents the compliance of the ventricle. Okay, if it moves in this direction, as it shows in this graph, that means reduction in compliance. Okay, it's a stiffer ventricle, so it is reduced compliance. All right. If it were to go in the other direction, theoretically, yes, that would be an increase in compliance. Okay. In other words, if I fill up with blood and it's a stiffer ventricle, you'll notice that there's an increase in pressure at any given point for the same volume. There's an increase in pressure because it's stiffer. It doesn't expand with the volume. Okay. Or it doesn't expand as readily with the volume, I should say. So that's why you see an increase on the base there, but there's no change in the contractility right here. So therefore, that slope stays the same. So look what happens though. If I have actually a stiffer ventricle and I can't fill it up with as much preload, you'll notice that the preload, here's our normal, all right, it's changed to this. So therefore, I actually have my preload is smaller. My end diastolic volume I start with is actually smaller. Afterload is effectively the same, all right? And you'll notice that it goes to roughly the same point, all right? So in having this stiffer ventricle and same contractility, I'm working with a smaller end diastolic volume. So let me go back to my ratio over here. We know that a reduced preload is going to reduce the stroke volume, and you can see that in the width of this box being smaller than the width of the normal. And the end diastolic volume is also reduced. It's not increased in this case. And since the denominator is decreased along with the stroke volume, it's usually in proportion. Okay, it's usually in proportion. So therefore, we have what looks like a normal ejection fraction. Okay, because they both go down and they both go down somewhat proportionally. So we call it a preserved EF, or heart failure with a little p, EF, meaning heart failure with a preserved EF. This is diastolic heart failure. This is a heart that is not relaxing. And you'll notice that in both cases, stroke volume was gone down. The effect on the EF had more to do with the end diastolic volume going up or down. Okay, so now let's talk about some of the pathophysiology of heart failure. So we've basically discussed two major categories for heart failure, and that is systolic heart failure and diastolic heart failure. So remembering here, so this is systolic dysfunction, so that's a reduced ejection fraction, and this is diastolic dysfunction with a preserved ejection fraction. So these are showing you the different types. So we have impaired contractility, right? So I'm talking about systolic dysfunction. Anything that causes impaired contractility, right? Because that's the reason we have the reduced ejection fraction. So coronary artery disease that leads to a myocardial infarction or even a transient myocardial ischemia can weaken the musculature of the wall and its ability to contract. Probably the most common reason, actually. Chronic volume overload. Okay, so this could be chronic mitral regurgitation, aortic regurgitation, which I've discussed the ins and outs of that in the valvular disorders lecture, as well as dilated cardiomyopathies, which I'm going to discuss a little bit later, which have specific etiologies which cause the heart to actually, the chambers to dilate and not contract very well. Now over here in this box, this is sort of an interesting thing that I have to discuss quickly, is that if I increase afterload, I can decrease stroke volume. Okay, it can also reduce my ejection fraction, but there's sort of a caveat here. So first off, advanced aortic stenosis or uncontrolled hypertension would increase the afterload, as I've mentioned earlier. Okay, that's the pressure that the ventricle would actually have to overcome, and if it's high enough, it will reduce the stroke volume and reduce the cardiac output, and can put somebody into heart failure. And if it's severe and acute, then you can end up with a systolic dysfunction very quickly. However, if it is more chronic, all right, if it is more chronic, then it can lead to a compensatory hypertrophy. In other words, that increased afterload over time, the heart will adapt to that, and by via adaptation, it'll thicken the muscle walls, just like any muscle with an increased load on it will learn to to get larger and hypertrophy in order to overcome that load. And so, if it's chronic, then we're going to end up with this situation down here. Okay, so let's discuss this situation really quick. This is impaired diastolic filling, meaning it contracts well, but it doesn't relax well. And so we have left ventricular hypertrophy. Okay, so this is a muscle that's the wall has gotten very thick. Okay, it's gotten very thick to the point where it's losing its compliance. Restrictive cardiomyopathies is the specific types of etiology or diseases of the musculature that cause it to stiffen up and fibrose. So we also have myocardial fibrosis as one of them. Transient myocardial ischemia can also cause it, so that can actually go both ways. It could be impaired contractility, or it could just impaired relaxation. Pericardial constriction. So remember, the pericardium surrounds the heart. If the pericardium is becoming fibrosed or rigid, okay, that's, since it's like a sleeve around the heart, if it becomes like a wall, it compresses the heart can't expand. And so that, even though the muscles, the heart itself may be fine, since it can't expand, it basically inhibits diastolic filling. So that could be due to stiffened pericardium or, say, tamponade, which is fluid around the heart. Okay. Now, there are some other types of terms you might hear for heart failure. The biggest ones are obviously heart failure with preserved or reduced ejection fraction. But there's also what we refer to as right-sided heart failure versus left-sided heart failure. Okay, left-sided heart failure, you'd see the key symptoms of dropping in blood pressure from the cardiac output and so on. And it can lead to things like pulmonary congestion because the lungs are in series with it, which can then lead to right heart failure. In fact, the most common cause of right-sided heart failure is left-sided heart failure. And in fact, if we see both left and right-sided heart failure with congestion in the lungs and edema systemically, that is commonly referred to as CHF, or congestive heart failure, okay, which is usually a combination of the both, right-sided and left-sided. However, there are conditions where you could have right side only. Less common, but it does happen. So you could have a lung disorder, okay, and this lung disorder, maybe due to some fibrotic lung tissue and whatnot, increases the pulmonary vasculature resistance, causing hypertension, and that can lead to hypertrophy and changes in the right side of the heart. Or if it's an acute edematous state in the lungs, maybe acute heart failure on the right side. Interestingly, though, the right side of the heart is very susceptible to changes in pressure. Okay, so in other words, if there's a sudden increase in afterload, it doesn't adapt as readily or as well as the left side does. The left side is more adapted for that. However, the right side does adapt to changes in volume a little bit better. So it has greater compliance in the left ventricle and accepts larger volumes more readily. So a couple of interesting things there. And cor pulmonale is really referring to lung disorders that affect the right side of the heart. So now the question is, if the heart is undergoing these changes where it has a sudden increase in afterload due to blood pressure or stenotic valve or volume overload, etc. What happens to the heart? What does it do? What are those compensations? And I kind of mentioned one of them already, and one that you guys know about, which is the Starling mechanism. So the Frank-Starling mechanism just means that by default, just what's characteristic of the muscle itself is that if I fill up the muscle or the heart chamber, let's assume it's empty, hypothetically, and I fill it up with blood, I'm going to expand the sarcomeres so that they align more optimally. And so what happens with a more optimal alignment, I'm going to get a better contraction. So in fact, the more blood that gets into the ventricle will actually produce a better and better contraction, to a point, of course. Okay, so initially, if the heart fails and fluid backs up into the heart or builds up in the heart, the initial compensation is simply going to be a better contraction due to that mechanism. Okay, which is which starts almost immediately as the volume builds up. So that's the first one. The neural-hormonal alterations. So this one's important, especially for how we treat patients or how we kind of alter their medications. So these neural-hormonal. So first off, one of the other adjustments that's made is via the adrenergic system, right? So if I want to increase contractility, sympathetic output would increase. So one of the responses to heart failure is an increase in sympathetic output, activating those major adrenergic receptors in order to increase contractility so I can increase my cardiac output. Okay, so that's with the adrenergic nervous system. It'll also activate the renin-angiotensin-aldosterone system via the kidneys, because what happens is if my cardiac output declines, the kidneys are very, very sensitive to blood flow and blood volume. And what they'll do is they'll sense a drop in the blood volume via, remember they have the juxtaglomerular apparatus, okay? If it has a decreased perfusion, okay, what's going to happen is it's going to release renin. Renin is going to activate angiotensin 2 and then ultimately aldosterone, and their actions are to vasoconstrict to help increase blood pressure as well as to conserve volume, all right? And then antidiuretic hormone can also be activated by angiotensin 2, okay? And that's also going to be, if there's a drop in perfusion of the kidney, it can also activate the antidiuretic hormone to conserve volume as well. So they're working together. And then natriuretic peptides actually do a little bit of the opposite. What's happening is they're sensing what's happening in the heart. So if the heart becomes expanded by a lot of volume because it's failing, ANP, all right, ANP and also BNP specifically, oops, let's erase that for a second. All right, and BNP, they can be released and activate the kidney to actually offset or release volume. Now, yes, you can have both of these systems running simultaneously, but generally speaking, the renin-angiotensin-aldosterone system will overwhelm the ANP and BNP effect. Okay. And then finally, you have ventricular hypertrophy and remodeling. And this is the one that takes the longest because the remodeling requires a lot of protein synthesis and so on. And this could take, usually weeks, days and weeks for this to really come about. And what you have is, again, what's important to distinguish here in this particular case is in the remodeling, we could have a volume overload kind of picture, or we could have a pressure overload type of picture. And you can also have combinations, of course. But let's separate the two for simplicity's sake. If I have volume overload, let's say I have a regurgitant valve, like aortic regurg or mitral regurg or something like that. That volume causes a lot of stress on the walls of the ventricle there. And in response to that stress, as well as in response to the elevated hormones like angiotensin 2, aldosterone, the catecholamines, it's going to undergo hypertrophic changes. Now, if it's due to the volume overload, the hypertrophic changes that undergo in the heart are referred to as eccentric. Eccentric hypertrophy basically means that the chamber is going to get larger. Okay, so you're going to get a larger chamber relative to the increase in thickness of the wall. So the thickness, it'll increase a little bit in thickness, but it's relatively a larger increase, relatively more of a larger increase in the ventricular chamber size. If it's a pressure overload, like a stenotic valve, like aortic stenosis, you can end up with concentric hypertrophy. This is actually where the chamber size will decrease and the wall thickness will be much thicker, relatively speaking. So we have a smaller chamber and a thicker wall. Okay, and so this is usually due to pressure overload because you need a lot of muscle and thick muscle to overcome that pressure. And again, like I said, you can have a combination of the two, of course. Deposition of extracellular matrix is also going to occur. Okay, it's going to try to build up, more proteins and so on to help with maintaining the stress that is now on the walls. So let's take a look at sort of the flow chart of this, of the neural-hormonal compensation. So a couple things we need to keep in mind. Cardiac output, so the cardiac output at the top here is equal to the heart rate times the stroke volume. And remember that blood pressure, again, I'm just going to write it up here. Arterial blood pressure is equal to the cardiac output times the total peripheral resistance. Okay. So we start off with a decreased cardiac output, because that's our sign of heart failure. And we're going to get in, let's start with the sympathetic nervous system, and we're going to increase in our sympathetic nervous system output. That happens usually within about 30 seconds or so. That's going to kick in due to the baroreceptor responses and ischemic responses from the heart and so on. So this is going to kick up very quickly. What that's going to do is it's going to increase contractility. It's going to increase heart rate. Increase in contractility will increase your stroke volume, as we discussed. Okay. Increasing the heart rate will increase your cardiac output based on our formula up here. Okay. An increase in stroke volume, of course, due to the contractility will also increase cardiac output. So those both are going to help. At the same time, though, sympathetics will also activate vasoconstriction, both the arteries and the veins. If it increases arterial constriction, that's going to help maintain blood pressure due to the increase in total peripheral resistance because it's going to cause constriction. Okay, so it's going to help maintain blood pressure. The caveat to that, though, or the problem I should say with that, is that this little dotted line is showing you that that can actually inhibit some of the cardiac output because it's going to increase afterload. So there's a little bit of give and take there. It's also going to venoconstrict, and what that does is that's going to actually move blood back to the heart and increase venous return, or in other words, increase the preload. That can result in peripheral edema in some cases because it's going to cause more fluid going to the heart, and that can cause more pressures systemically, and that can result in fluid overload and congestion. Okay, but at least initially, it's supposed to help because by increasing the preload, right, it's going to increase our stroke volume. So by increasing preload, we're increasing contractility, we're increasing our stroke volume, which is going to increase our cardiac output. So initially, it's very helpful. Okay. Now, in terms of the renin-angiotensin-aldosterone system, in response to low flow to the kidneys, it's going to cause vasoconstriction, but this is now via angiotensin 2, and that's going to be arterial and venous, and the same thing happens. Okay. And it's also going to increase circulating volume. So this is a little bit different. It's increasing volume, and it's increasing volume by increasing aldosterone levels, as well as antidiuretic hormone, for example, which is over here. All right, so that can increase the volume. That's also going to increase preload and venous return, increasing stroke volume. If it's overly done or the heart's really in severe failure, then it's going to cause things like congestion. Now, the natriuretic peptides over here, AMP and BMP, they would release volume or lower the volume. Okay, so they would sort of counteract some of the increase in volume. Now, BMP is particularly useful clinically because it correlates very well with ventricular myocyte stress. So if there's a very elevated BMP, it's usually reflective of a very stressed ventricle. Okay, so the more severe the heart failure, the higher the BMP would be. Okay, so what I want to show here is in clinic what we refer to as compensated heart failure, and just to kind of give you an understanding of sort of the process of compensation. All right, so let's start with here. Let me quickly draw this graph for you guys. So this represents cardiac output, okay, which is in our liters per minute. Sorry about that. And then we have what I'm going to draw here on this axis, okay, is something which you'll see called right atrial pressure. Right atrial pressure, and that would normally be in millimeters of mercury. Now, right atrial pressure, just to kind of remind you guys that when it comes to right atrial pressures, typically in a normal pressure gradient, what we have leaving the aorta, or the pressures in the aorta, the mean pressure is typically right around 93 millimeters of mercury, and that pressure drops as we go all the way back to the right side of the heart, which we've discussed in physiology. That pressure drop goes all the way to the right atrium, because that's where the stomach veins, empty into the right atrium, and that's the lowest pressure point, which would be right around 0 millimeters of mercury. So what I'm going to draw here, I'm going to draw 0 right about there. Okay, so here's, say, -2, -4. So I'm just going to draw some pressures here for, sorry, it's a little overlap there, it's a little ugly, sorry. All right, and then the cardiac output at this point here would be 0, say 5, and 10. And we'll go up here, it'd be 15, let's say. All right, so let's clean this up a little bit. Okay, so let me just rewrite that as right atrial pressure. Okay, so I'm going to draw the first graph here. And what I want to show you is a normal cardiac output curve. Okay, approximately is our normal cardiac output curve. If you guys remember, at rest, our cardiac output is about 5 liters per minute. So I'm going to draw my 5 liters per minute right about here, which is going to coincide approximately with my right atrial pressure of about 0. Okay, give or take. So here, from here to about here, let's say. All right, that's a cardiac output of 5. Our right atrial pressure of 0. That's our normal sort of working baseline right here. Okay. I'm going to draw another curve. And on this curve, we're going to say about here. I'm going to draw one that's much lower. And what this curve represents is acute heart failure. And we're going to say that the person just underwent, let's say, some sort of myocardial infarction, for example, so some sort of ischemic cardiomyopathy. All right. And I'm going to draw another point right about, say, about here. All right. So we see a change now from here to about here. So let's talk about that for a second. Person suddenly has a heart attack. The pump has failed due to the ischemia of the muscles of the wall, so they don't contract as well. And so what happens is my cardiac output curve is now dropped to here. But what you'll notice is that the right atrial pressure has actually gone up. Okay, it's typically right around 0. Okay, with a cardiac output of about 5 liters per minute. But when there was failure, I now have a new curve. Okay, a reduced curve, meaning I can't achieve the same cardiac output. So that's why the curve is lower. You notice the right atrial pressure has gone up. So what this means is that if I don't eject as much blood, okay, if I can't eject as much blood, what that means is that I have buildup of blood in the heart. That buildup of blood in the heart is going to increase pressures. All right, so you get an increase in pressure there because now I have venous return and I'm not ejecting as much blood. It's staying behind, expanding those the atria and the ventricles and so on. So right atrial pressure is going to go up. So I'm not moving it as effectively. Now, about 30 seconds in or so, what's going to happen is I'm going to get a quick compensation from the sympathetic nervous system. So this represents the sympathetic response. Okay, and what's happening here, all right, is going to basically move me to approximately, let's say, a point right along here. So we'll draw the line to there. So this was point A, B, and C. So what happened with the green line now is in about 30 seconds after that acute episode, all right, where the fluid backed up, my right atrial pressure went up because of that. Now the sympathetic nervous system kicks in and it increases my contractility, all right? Increasing my contractility is going to increase my stroke volume, and thus my cardiac output goes up. So you notice it goes up. So my cardiac output's going up because I'm increasing my contractility. I'm also on a new curve now, okay, because of my change in contractility. Now, you'll notice that the sympathetic activation will also increase venoconstriction, which means there's going to be an increase in venous return, which means more volume returning to the right atrium, which means an increase in the right atrial pressure, which is why you see that go up too, from say about 4 to about 6 or so. So right atrial pressure has gone up as well. Okay. Now, even with this sympathetic response, I'm not back to my baseline cardiac output just yet. So finally, in a matter of minutes, the last thing that's going to happen here is I'm going to hit, say, about point D here. And what point D represents is now the the second compensation, which is the renal compensation. Okay, so what you have here is renal compensation. And by renal, what I mean really is the renin-angiotensin-aldosterone system. By increasing volume, venoconstricting some more because the angiotensin 2 is going to increase right atrial pressure further. Okay, and then finally, that increase in volume again is going to also increase right atrial pressure. So that's why we see this increasing right atrial pressure. But you'll notice what happened is, by the time the sympathetic and the renal compensations has occurred, my cardiac output curve has not changed, meaning I can't actually increase my cardiac output much more than that. I'm pretty much at the plateau already because this is the condition of this now failed heart. However, it managed to get me back to level with my initial cardiac output. So why is this important clinically? Well, clinically, if I'm measuring cardiac output alone as my only index for heart failure, what you're going to notice is that their cardiac output may be normal. So the cardiac output could be normal. If I take a catheter and I insert that into their right atrium, remember we talked about catheters in the first lecture. If I take a catheter and I take a look at what the pressure is in the right atrium and I see that the right atrial pressure, it should be close to 0, but instead I see it's about 8 millimeters of mercury or so, like in our example here. What that should suggest is, although the compensation has returned the cardiac output to normal, so they're functioning maybe essentially normally otherwise, the elevated right atrial pressures now suggest that this person has compensated heart failure. So that right atrial pressure gives away the fact that there was compensation that took place. And the right atrial pressure went up because of all these volume increases into the right atrium. Okay, so that kind of gives you an idea of clinically how we could actually diagnose somebody with compensated heart failure who may have a normal cardiac output, for example. And also how the sympathetics and the renal would work work together in order to help return us to a normal cardiac output. Understand that the kidneys, they are exquisitely sensitive to a drop in perfusing pressure. And so therefore, renin-angiotensin levels will elevate and stay elevated until the kidney is essentially satisfied with its perfusion. It has like a preset perfusion level that it's looking for. And if the heart never meets it, it will continue to pump out those hormones until it does, and that could effectively cause the heart to completely fail if it never goes back to a normal cardiac output. Once a normal cardiac output is reached, however, the kidneys will become happy, and then those hormone levels will, may dissipate a little bit, and they, start to excrete excess volume at that point. But now we're at a new set point. So, in terms of this failure of heart, we have myocyte loss and cellular dysfunction, right? So There could be necrosis due to drugs or an infarct. What's interesting here, though, is you could have apoptosis. Okay, so let me just color here. We could have apoptosis of some of the muscle wall, which can cause it to weaken. And interestingly, here's the problem. The mechanisms for us to compensate, increased angiotensin 2, aldosterone levels, as well as catecholamines, prolonged, if those hormones stay elevated for a prolonged period of time, it's actually detrimental to the heart over time, because the catecholamines themselves can actually downregulate beta receptors and reduce its contractility if it's excessive and prolonged. It can also induce apoptosis. Angiotensin 2 can actually, and aldosterone can increase cytokine synthesis and inflammatory reactions, as well as scarring and fibrosis in the heart, as well as inducing apoptosis. So that, and also in conjunction with mechanical strain, all of this kind of mixed together over a prolonged period of time means that the heart is going to have an effective compensation, but if it's prolonged, could ultimately fail and work against it. Now, oftentimes when you see these patients coming in with heart failure, there's usually a precipitating factor, like it was being maintained, and then something caused it to go into failure. So we refer to that as a precipitating factor. They had a fever, maybe they had an infection of some sort, anemia. I have a whole list right here, right? So something they're hypertensive, or they have an embolus, or they had an MI, which is the example I've been using, or their medications. Okay, so there's many different reasons that might actually cause the heart failure, or the heart to go into the failure. Some of the clinical manifestations of heart failure, things we've actually talked about in the previous lectures, but dyspnea, fluid backing up in the lungs, mental status changes from a low cardiac output, so the brain's not being perfused well, oliguria, you're not perfusing the kidneys well, they're retaining volume, so you're not urinating, fatigue and weakness from low cardiac output, hemoptysis from rupture of the vessels, nausea. So this can also cause issues both in the brain as well as in the GI tract, which can stimulate nausea. Peripheral edema. So sometimes patients may actually see weight gain in a heart failure picture. They may be edematous and may not even notice the edema, but it may be causing weight gain from retaining water. Now, for the most part, heart failure is really a clinical diagnosis. Okay, and the New York Heart Association has a classification for chronic heart failure. And so we need to be familiar with this, and so you need to know this chart. So we classify it from class 1 to 4, 4 being the worst. 1, essentially they're classified in 1 is there's no limitation of physical activity, so they have normal physical activity, there's no breathlessness, there's no fatigue, there's no palpitations or any symptoms. Okay, but otherwise you can see that measurements on echo and something are suggesting heart failure. So it would be class 1. Class 2, there's slight limitations to their physical activity. Maybe they can't walk upstairs as readily, but they can do other activities just fine. So it may cause a little bit of breathlessness, fatigue, or even palpitations. Class 3 is marked limitation of physical activity. Okay, they're comfortable at rest. Okay, in class 3, they're still comfortable at rest, but less than ordinary activity is going to result in undue breathlessness. And then finally, class 4 is the worst of the 4. Unable to carry on any physical activity without discomfort, and usually they'll have symptoms at rest as well. Some of the signs for heart failure is cachexia, which is really just more of a wasting away, and again, that could be due to that low cardiac output. Diaphoretic from sympathetic overdrive, tachypnea, tachycardia, again, sympathetic activation. Pulsus alternans is really just a weak pulse and then followed by a strong pulse and then a weak pulse and strong pulse. It just has to do with the fact that the heart may have a weak ejection of a stroke volume, so there's a weak pulse, but now there's more volume left in the ventricle, and so that larger volume causes an increase in stroke volume in the next one because of the Starling mechanism, so you get a stronger pulse, and then the next one is weak again, and so on. Pulmonary rales, so you can hear that in the lungs, rhonchi and wheezing, sometimes referred to as cardiac asthma. You could hear an S3 or an S4 in heart failure, it depends on the type, right? If it's diastolic heart failure, you'd hear an S4 due to ejection to a very stiff ventricle, or an S3 from systolic heart failure. can get a murmur or a heave, depending on what the underlying issues are. JVD, hepatomegaly could happen, again, from backed up pressures, edema, dullness to percussion, and so on. As far as the diagnostic tests are concerned, history and physical, because heart failure is really a clinical diagnosis, are really key. And picking up on things like orthopnea, paroxysmal nocturnal dyspnea, dyspnea on exertion, and so on. Any kind of breathlessness is one to keep in mind for heart failure. Chest x-ray. When you look at chest x-ray, you look at the lungs for any kind of congestion, especially if they're having breathlessness of any sort. And look at the size of the heart silhouette to look for any kind of left ventricular hypertrophy or cardiomegaly. The BNP assay, like I mentioned earlier, could be indicative of any kind of strain on the ventricle. And echo is going to really be our go-to in measuring left ventricular function, because really we need to be able to figure out whether this is systolic or diastolic, because the treatments will vary for it. Okay, so it's important for treatments. Even though the outcome is the same, it's reduced cardiac output, the treatments are not the same. So we need to be able to distinguish one type from another, right? Preserved versus reduced ejection fractions. We can measure that with an echo. We can also see how the ventricles are moving and so on. An EKG or an ECG would be useful, may show hypertrophy, which could be handy. If they're having an MI, we would need to know that, because we have to treat that first. And then catheterization could ultimately show us things like pressure. We would know if it's compensated heart failure. We'll be able to look at the coronary arteries, if there's coronary artery disease, and so on. So pulmonary congestion, and this is just an example of a chest x-ray you might see. So in this case, what these little arrows are showing are curly B lines, which you can kind of see one right there and some over there. They're usually on the periphery, and it's really a demonstration of interlobular edema of the lung. In fact, you can see one of the lobes is demarcated over here. Okay, one of the fissures there, the lung, you can actually see here, it's edematous. It's actually been outlined by some of the fluid there. You can also see some blunting of the costophrenic angles over here. Okay, so other little characteristic signs is let's see, peribronchial cuffing, which you can see some of, a little bit over here. Okay, which is basically fluid around the bronchioles there. So basically, this is an edematous picture. You can also see that there's, if you look at the border of the heart over here, looks like left ventricular hypertrophy as well. So this kind of fits that picture. Okay, so now treatment. This is treatment specifically with heart failure with a reduced EF. So just to remind you guys, that means systolic dysfunction. So it's not contracting well. Okay, so that's going to be different from obviously one that's not relaxing well. So we have 5 goals. Identify and correct the underlying condition. Okay, so if there's a valvular disorder or something like that, that's something we have to correct, which may be contributing to the heart failure condition. We want to eliminate any of the precipitating causes, so why'd they end up here? So they may have had an underlying valvular heart disorder that had been leading them to heart failure, but they're not here at the hospital necessarily due to that, but because they suddenly have an infection or something else going on, or an MI, then we have to take care of that, right? So we have to make sure we clear up that precipitating cause. Then we want to manage their symptoms, right? Their heart failure symptoms. So treatment of any kind of congestion. So if they can't breathe, we've got to give them something like a diuretic so we can offload some of that volume. We want to make sure that we increase their cardiac output, so something that may increase the contractility of the heart, because this is a heart that's not able to contract really well. So we'll discuss that on the next slide. We want to modulate the neural-hormonal response. So essentially, in the long run, after we help manage their symptoms so they can breathe again, for example, we want to be sure they're on medications that are going to blunt the neural-hormonal response for the reasons I gave. For example, catecholamines, angiotensin II in the long term can cause things like scarring and apoptosis and cytokine release. We want to make sure we want to minimize that. And then we want to make sure we give them anything that's going to prolong their long-term survival. Okay? And lower mortality. So we need to know what medications lower mortality. So this is the treatment for heart failure with a reduced ejection fraction. This is looking at sort of medications and also surgical options. So I want to draw your attention over here to the graph. So we understand again that this is our zone of pulmonary congestion. Here's our hypotension. This is looking at stroke volume or cardiac output, and our end diastolic volume or pressure. Okay, here's our normal, and then here was our sudden heart failure. Okay, and let's just say we're operating now at point A. Point A represents our position on the heart failure curve now, and you notice the heart failure curve is fairly flat compared to our normal. You notice that point A is actually in the pulmonary congestion zone, which means this patient would have congestion, dyspnea, and difficulty breathing. Now, we might want to give a diuretic for this, right? So point B represents initiation of a diuretic. Now, you have to be careful with a diuretic. Although you want to use a diuretic to help offload some volume so that they can breathe, you have to be very judicious with its usage, because if you use too much of it, look what happens. We can go to B prime. If you use too much and you offload too much volume, look what happens to their blood pressure. We're now in the hypotensive zone. You could drop so much volume, this person actually becomes hypotensive, and now that's obviously counterproductive to what you're trying to do. So you have to be very careful with the usage of it here. But the idea is to offload just enough to make sure that they can breathe without compromising their cardiac output. Obviously, it's going to go down a little bit, but this curve is fairly flat between A and B, and so we're not sacrificing too much stroke volume by doing this. Okay, but too much, obviously, we become hypotensive. Now at point B, we're no longer congested, we're not hypotensive. We sacrificed a little bit of stroke volume, but this was beneficial for the patient. Again, we would only use a diuretic if they had congestion. Okay. Now here, that could be point B. Now another thing we can do is at point C, for example. That's what happens if you give an inotrope. So something that increases the contractility of the heart would help to improve, put us on a new functioning line, for example. So that would greatly improve our contractility, okay? And it could improve our stroke volume, but it may or may not get us out of that congested zone right there. D over here, that's if you use a vasodilator. In other words, I'm reducing the afterload. If I use a vasodilator, I decrease the afterload, so that decreases the pressure which the heart has to eject against, okay? And at the same time, it could also, the vasodilator can be a venous dilator and an arterial dilator. If it's an arterial dilator, it reduces the afterload. If it's a venous dilator, it decreases the venous return. Decreasing the venous return is an added benefit of not volume overloading the heart, and it can help with congestion especially. E represents a combination of using an inotrope as well as using a vasodilator. And so that's really kind of optimal. We give a little bit of a diuretic, and we combine it with a vasodilator and an inotrope, and we'd end up with much better function overall. Okay, so that's the goal. So with diuretics, we can use loop diuretics, furosemide, torsemide. They work very well, IV formulations. Vasodilators. The vasodilators, ACE inhibitors. I highlight anyone that's highlighted in red decreases mortality. So they're ones that you should know. So ACE inhibitors, they actually dilate the veins and the arteries. So that helps with the issues I talked about. Decreases afterload as well as decreases preload. So reduces the amount of volume that the heart is being stressed out with. It does decrease mortality, and some of that benefit may be coming from the fact that it increases the levels of bradykinin, but it's not certain. Nitrates are good venodilators, essentially. They also do dilate the coronaries, which we'll discuss later, but that can offload some of the volume or the preload. Hydralazine is more of a specific arterial dilator, and so that can actually decrease afterload, and those combinations can be used, especially if they can't tolerate an ACE inhibitor. Usually you try to shift to something like an ARB, which is fairly effective as well. Now a positive inotropic, so if I wanted to contract better, like at point C, which we talked about, dobutamine, digitalis, but they're not going to decrease mortality, but will improve the cardiac output. Beta blockers. Now this may seem counterintuitive because beta blockers are actually, they're non-inotropic. They're actually going to decrease inotropy, decrease contractility. They do actually reduce mortality. Now, the issue with this, though, is you don't give beta blockers in an emergent situation. If the person's in an acute heart failure setting, you don't want to decrease their contractility. That's a no-no. What you're trying to do is give this to a patient who has chronic, stable heart failure. Okay, so they're stable is the key here. All right. Now, you would give this in very small doses at first to see how they tolerate it, but the idea is by giving a beta blocker, you're also blocking the catecholamine levels that can cause counterproductive levels of catecholamines that can induce apoptosis and so on, or reduce beta receptor levels. So it helps to kind of counteract some of that, as well as the fact that it's anti-ischemic and so on, so it could be useful. In fact, ACE inhibitors, the vasodilators, they are also lowering mortality, and some of that function may come from the fact that they inhibit angiotensin and aldosterone, which elevates cytokine levels and can induce apoptosis over prolonged periods. So in addition, you could also add aldosterone antagonist, a specific one like spironolactone or eplerenone and so on. There's other formulations of it. Oftentimes that's held off until the ejection fraction is less than 35%, where it has its best effect. It can be added though in conjunction with beta blockers and ACE inhibitors for a better effect. You would give it at a very low level so it doesn't have its diuretic effect, so to speak, because one of the issues you're going to run into with these medications is that it increases potassium levels. Because if you're blocking aldosterone, you're going to retain more potassium. For example, beta blockers are known to increase potassium levels, and ACE inhibitors, for the same reason of blocking aldosterone, can increase potassium as well. So you have to be very cautious of potassium levels with these medications. Some other things that you can try, antiarrhythmics or an ICD if the ejection fraction is less than 35%, because they are at risk for fatal arrhythmias. Cardiac resynchronization might be necessary. You can use mechanical assist device to help them get them to transplant. And there's some other, other modalities we can use to make sure we can kind of maintain the patient to maybe undergo surgery or maintain some sort of cardiac output until something else can be done. There are actually other drugs on the market now that can lower mortality. In fact, one of them is, I believe, valsartan in combination with another drug. And I'll have to talk about the drug with you guys live because I don't remember the name off the top of my head. But ultimately what it does is it inhibits the enzyme that breaks down AMP and BMP. So AMP levels and BMP levels will rise and it'll lower volume. Now, in terms of the treatment with heart failure with a preserved EF, goals are relief of pulmonary and systemic congestion, address any correctable cause of impaired diastolic function. Okay. Treatment in diastolic dysfunction is a bit different because it can contract just fine. So what happens is you also have to be careful with a diuretic usage because these ventricles don't fill up very readily. They're not very compliant. And if you offload too much volume, then you're reducing the preload even further than it already is. And so you can compromise cardiac output. So you have to be very careful in that case. Vasodilators, you use an ACE or an ARB. They do not, none of these medications, there's no medication that we have that lower mortality in this type of heart failure. But it can help reduce, symptoms and maybe the progression of the disease. So vasodilators reduce that afterloads, maybe improve the cardiac output a little bit, but less strain on the heart. Beta blockers, the beta blockers are useful in this case because it's not an inotropic agent, so it blocks that. The idea would be to give it more time to fill up. Since it's having difficulty filling due to high pressures during diastole, give it more time to fill. You have more volume. That might be helpful. Aldosterone antagonist again may be useful. And just to reiterate, these are not lowering mortality at all, but to help to alleviate the symptoms and the progression. Now, on this slide, what I really want to just touch on with you guys is just to quickly talk about a scenario that you guys are going to come across in hospitals or in clinic where you have somebody who has an acute heart failure and quick ways to assess an acute heart failure patient, okay, and ultimately how to progress with that. So when we look at an acute heart failure patient, let's say we're in a clinic or we're actually, let's say we're working in the cardiac unit at the hospital. And somebody suddenly goes into heart failure. Well, ways to assess the patient if they're going into heart failure is based on volume, okay, volume overload and perfusion. So when we're talking about volume, it's wet versus dry, we call it. Are they wet or dry? Meaning, if you listen to their lungs, do you hear any crackling or wetness? Okay. Is there edema? Do they have JVD? These are all signs of volume overload, and if you see them, we would say that that's wet, okay? Versus not having any of those would be dry. Signs of decreased cardiac output and perfusion lead to cold versus warm. So you're gonna touch the patient and feel if they're cold or warm. So that's one way to kind of assess. Do they have cold extremities? Okay. Do they have a narrow pulse pressure, meaning it's poor cardiac output? If you're not ejecting much, the pulse pressure itself goes down. And they could be obtunded. In other words, they could be confused, have changes in their mental state due to poor cardiac output. These are all signs of what we refer to as being cold or poor perfusion versus warm, which would be our normal state. So we look at the grid over here, low perfusion at rest and congestion at rest. So if they are warm and dry, that's our normal. So if they're having problems breathing or having some other issue, but they're warm and they're dry, then you might want to look for other reasons that they may be having these symptoms or these issues. If they're warm and wet, so that's B. Warm and wet, so basically they're warm, so they're perfusing okay, but they're wet, meaning there's some volume overload. So you're hearing rales, or they're edematous, or they have JVD. So you might want to initiate something like a diuretic to help offset that, for example. Cold and wet is the worst of the scenarios. This is where they're not perfusing well, the cardiac output is compromised in some way, and they're also backed up volume-wise. So this is where you're going to be thinking about adding an inotropic agents, antihypertensives, diuretics, and so on. Cold and dry, in this scenario, this is more of a unique scenario. This is where you have somebody who's not volume overloaded. You don't see any JVD or anything like that. They're dry, but they're cold, which means they're not good cardiac output. So this is looking at like a decreased volume status, not a volume overload, but a loss of volume. So this might be somebody who needs fluids, for example. Okay. Ultimately, the goal for this is to normalize ventricular filling pressures and restore adequate perfusion. Right? So the medications are geared towards that. And it's the medications that we just discussed, but this is a way to assess that patient for an acute situation. And again, if it comes to a patient who can't breathe, okay, so somebody with dyspnea, there are ways to approach that. So a couple of things to keep in mind with somebody who can't breathe, who's having heart failure type symptoms. You don't want to lay them down flat, because you lay them down flat, that increases venous return. Okay, so in terms of position, keep them upright. Okay, upright will help reduce venous return. All right, so you can also give them medications that reduce venous return. Things like nitrates. You can also give them diuretics like Lasix, which can help offload volume. These are things that can help to kind of offset that. So these are sort of things to keep in mind when you have a patient who can't breathe, who might be undergoing heart failure. Okay. All right. This is for you guys to look through. I want to make sure you guys read through this case. Okay, so this is the presentation of the case, so I'll leave you guys to read. Here's the ECG for that case, which we will discuss, the chest x-ray, and a couple questions for you guys to kind of think through, and then I want you guys to kind of think over possible treatment scenarios for what you think might be going on. All right, so now I'm talking about the cardiomyopathies. These are disorders of the muscles themselves, okay? Now, there's three types. We have dilated cardiomyopathy, all right? We have hypertrophic cardiomyopathy, and we have restrictive cardiomyopathy. So those are the three categories. Dilated cardiomyopathy is basically systolic, impaired systolic contraction. So this is present with a reduced EF, similar to what we talked about, okay? In fact, the most common etiology for this is coronary artery disease. Okay, so it's a prior myocardial infarction, for example, and oftentimes referred to as ischemic cardiomyopathy. Other etiologies that would affect the muscle tissues would be something like infectious, so viral, Coxsackie virus, HIV, could be something like Lyme. Something toxic, excessive alcohol intake can cause that, cocaine, chemotherapy, peripartum state, so after pregnancy. That can actually fully recover sometimes. Gene mutations, okay, so it can be familial in some respects. Metabolic could be something like hypothyroidism causing it. All right, so it's going to be important when you're trying to diagnose the patient that we're not just treating the heart failure and its symptoms, but what the underlying cause is, because some of these can be reversed, right? So if we treat hypothyroidism, we can reverse some of these problems. The pathophysiology, oftentimes it's enlargement of all four chambers out of proportion to the thickness of the wall. All right, there's myocyte degeneration, atrophy, interstitial fibrosis. Okay, the cardiac output declines. All right, the Frank-Starling mechanism can compensate, and the neural-hormonal activation will kick in as well. So you will see a lot of what we see with heart failure. Okay, decompensation follows a pattern of heart failure with reduced EF. And oftentimes, because these chambers are enlarged, as they enlarge and stretch out, they tend to pull on the annulus that's connecting the valves, and it can cause the valves, the leaflets, to pull apart, resulting in regurgitation. Okay, which can further exacerbate the problem of volume overload and so on. And so what you're seeing over here on this side is just a very large chamber. And like I said, oftentimes you can see it with all four chambers, actually, if it's a specific etiology here, not necessarily with coronary artery disease. So for the exams for this, it's going to basically present similar to heart failure. So we can kind of just review that, okay? Cool extremities, low blood pressure, rails, dullness, percussion. In this case, you would hear an S3 because that's what you would hear in systolic dysfunction due to a very large chamber. Chest X-ray, you can see a large silhouette. ECGs might show various arrhythmias. You might see hypertrophy on the ECG. AFib, VTAC, and so on. Echo, enlargement of the ventricles is going to be kind of critical for some of our diagnosis. The catheterization, okay, or a CTA, which is a CT angio, can tell us about if there's any coronary artery disease that exists with this. We can also take a biopsy. So these catheterizations will actually become very important if we think there's really a specific underlying etiology outside of something like coronary artery disease. We can biopsy the muscle tissue and actually evaluate that to see, what might be going on, or culture it, and see if there's some sort of infection or so on. An MRI can actually be good in differentiating inflammation due to myocarditis, as opposed to local ischemic effect, which can only be in part of the ventricle, versus the entire heart being affected by some infectious cause. Now, myocarditis, by the way, to differentiate from cardiomyopathy, cardiomyopathy is generally more of a chronic condition, whereas myocarditis is an acute inflammatory condition, which can lead into a cardiomyopathy chronically. The treatment, we treat the underlying disease, really is what we're looking for. So, change the, if it's thyroid, sarcoid, or something of that nature, we try to treat that underlying disorder. Otherwise, it's the same as heart failure. Use diuretics, digoxin for contractility, salt restriction to help offload the volume, ACE inhibitors, beta blockers, aldosterone antagonists. And again, beta blockers, you would only use that in cases of patients who are stable heart failure patients, who are stable hemodynamically. You want to prevent any kind of arrhythmias, so antiarrhythmics, which we'll talk about more in another lecture, but amiodarone and a possible ICD, a defibrillator. You may need to prevent thromboembolic events because of, an acquired atrial fibrillation, for example. May require transplantation ultimately. So in hypertrophic cardiomyopathy, this is the second type. This is where there's hypertrophy that's similar to like a concentric hypertrophy, where there could be smaller chambers and very thick walls. Okay. Now this hypertrophy, though, it's important to note that this hypertrophy is not caused, is not caused by chronic pressure overload like aortic stenosis or hypertension. It's not caused by that. Instead, it's more often this is a familial autosomal dominant condition with variable penetrance. Basically, what's happening is you're getting abnormal hypertrophy when there shouldn't be any hypertrophy or any compensations per se, and then the muscles are laying down in a fashion that's sort of disorganized and disarray, and not in a coherent, cohesive way that would be conducive to a good compensatory mechanism. And it can happen in, most often, the septum of the ventricle or along the lateral wall, or basically anywhere in the muscle, to be honest, but it would usually show like a focal thickening of the wall, but it could be more diffuse. Now, importantly, 33% or about a third manifest this hypertrophy in the systolic outflow tract, meaning the from the left ventricle into the aorta, that outflow tract, you can have a thickened wall right there. So it creates kind of a stenosis as the blood is trying to leave the left ventricle. And so this obstruction involves an abnormal mitral valve motion. So basically the mitral valve is very close to the outflow tract of the blood leaving the ventricle. And because of the anatomic proximity of these two, if the blood that's being ejected through this very narrow area, okay, the blood that goes through that very narrow area, the blood picks up velocity as it goes to a very narrow area. Similar to if you had a hose with no nozzle on the end of it, kind of pours out, but if you stick your thumb on the end of it and create like a little stenotic opening, the hose water sprays out much faster. Same effect. What happens is you have a bulging of the muscle that's below the aortic valve. So it's not the aortic valve that's involved, but it's below that. It's creating a bulge that's creating a narrow opening through to get to the valve. And on the other side of that is the mitral valve. So what happens is there's an increase in velocity, and you have something called the Venturi effect, which is the increased velocity of blood flow going through that very narrow opening causes the valve leaflet of the mitral valve to pull towards the ventricular wall there and close it off. So it can obstruct. It can actually obstruct the outflow tract. And so that's what we're saying down here, draws the mitral valve leaflet toward the septum. And so that can actually cause complete obstruction and a complete drop of the cardiac output. And so let's show. So here is our normal heart. Here is the hypertrophic cardiomyopathy. Hypertrophic cardiomyopathy with obstruction. So basically what you're seeing in this version over here is you see thickness, really a lot of thickness of the ventricular wall, maybe even portions of the lateral portions of the wall there, all very, very thick, but it's not a coordinated, well-maintained thickening. This can have a lot of fibrotic tissue in there and misaligned musculature. This can also affect the conductive pathways that travel through the septum, like the bundle branches and so on. So it can cause arrhythmias. And so what happens is that can affect any of the bundle branches that are traveling through the septum there. All right. Now over here, what you're seeing is a bulging of the muscle, and here's the outflow tract. So this is the left ventricle over here. This is the left atrium, and normally the blood would go through past that opening through the valves right there, the aortic valve into the aorta. But you notice it bulges and closes off some of that pathway, and that can cause the valve leaflet of the mitral valve to kind of come and come close proximity to it and close it off. And that's particularly the case if there's low volume inside the left ventricle. If you have a larger amount of volume in the left ventricle or a larger preload, what happens is that actually stents open that area and prevents the valve from really being able to touch the septal wall and obstructing it. So in this particular condition, it's really important to make sure that volume stays higher, because you want to make sure that that doesn't close off the outflow tract there. Okay. On an exam with this, classically what you see is somebody who's young, mid-20s. In fact, mid-20s with shortness of breath, they may have even anginal pain. And this is one of these stories, these horrible stories that you hear about of a young athlete who dies, who drops dead suddenly on the field. And this is because of hypertrophic cardiomyopathy, and or sometimes referred to, you may see HOCM, or hypertrophic obstructive cardiomyopathy, which is really kind of referring to the obstruction that's caused over here in that condition. And what happens is, because of this familial condition, they get hypertrophy, that part of the heart, and they can get complete obstruction there. Their cardiac output could drop. But really what's happening is, because of the damage it can do to the conduction system, they usually go into a fatal arrhythmia like VFib or VTAC or something of that nature, which causes the sudden death that you see in some of these young athletes. So syncope, orthostatic hypotension due to the drop in cardiac output, AFib or VFib, the murmur of HOCM or HCM. Now, as I mentioned during the auscultation or the heart sound lecture, the general rule is any increase in blood volume will increase the sound of a murmur. This is the exception to that rule. An increase in blood volume in this case is going to stent and keep open that that aortic outlet, excuse me, that ventricular outlet. If there's less volume there, what happens is the mitral valve and the septum wall come closer together because there's no volume to stent it, to keep it open. So with that less volume means they come closer together, making more of a narrower opening, and you can actually hear more turbulence. So in this case, this is where a low volume status would actually increase the sound. This is important in differentiating from aortic stenosis, because the aortic valve is very close to that, but it's not what's causing this murmur. So in other words, if I increase the volume, aortic stenosis would increase. The murmur would increase in aortic stenosis because that's what normally happens with every other type of murmur. In this case, when you have an increase in the volume, the murmur actually gets lower or goes away. And so that's how we differentiate, on physical exam, how we can differentiate the two. Okay. We can do, ECG would show left ventricular hypertrophy, left atrial enlargement. Give or take, it may or may not show anything on an X-ray because the hypertrophy is causing smaller ventricular size, not necessarily thicker walls with a smaller chamber, but not necessarily an increase in overall size that you would see on an X-ray necessarily. It's going to be important to genetically test the family and of any patient that comes in with this condition because it is familial and it is autosomal dominant. Treatment for this, beta blockers, that can actually help offset some of the symptoms. It does not reduce mortality, but would help increase filling time, and that'll help increase the volume and prevent some of the obstruction. Calcium channel blockers have shown to have some effects, may help as well in the same vein that beta blockers might help in letting the heart fill up and so on, but they're usually more second line. Diuretics, again, the diuretics we don't want to reduce the volume too much again because we're going to cause obstruction or reduce that preload, which is vital. But if they're congested, then you might have to add a little bit to offset the congestion, but not too much to decrease their preload. Antiarrhythmics like amiodarone if they're having any type of arrhythmia. We'll discuss that again more later. But definitely in this case with these athletes, it's a matter of avoid any strenuous exercise. They have to stop, and so no competitive sports. Some benefit from an ICD, especially since their risk could be higher for these fatal arrhythmias. So this could be something that increases lowers their risk for these arrhythmias. Surgical myomectomy is another sort of gold standard, which is if they're not responsive to some of the medications, then you can actually resect some of the wall there. There's also percutaneous septal ablation. In this case, you're using more of a catheter that injects something that causes the erosion of the wall there. And they have to get genetic counseling with the family to make sure that everybody else, so you're essentially screening, family members for this condition. Okay, restrictive cardiomyopathy, which is the last of the cardiomyopathies. This is where there's impaired diastolic relaxation. So this is similar to hypertrophic in the sense that there's impaired diastolic relaxation. Okay, so it's going to present in a similar manner. The difference here, though, is that first off, this is the least common of all the cardiomyopathies. Okay, it usually has the poorest prognosis, and there's not necessarily any hypertrophy or thickening of the walls. Instead, you can just get a rigid wall because you have some sort of fibrous scarring, maybe due to radiation, scleroderma, infiltration by some particular substance like hemochromatosis or a tumor that's actually just invading the tissue and causing it to stiffen, but it's not thick, it's not hypertrophic. Or proteins like amyloidosis in some cases of multiple myeloma, for example. Now what happens is it's essentially you have a reduced compliance of the ventricle, all right, it's stiff, so diastolic filling pressures go up, cardiac or stroke volume can go down because of that. You can get elevated systemic and pulmonary venous pressures because of the increased pressures in diastole. And you could get reduced ventricular cavity size with reduced filling as well. Stroke volume goes down, cardiac output goes down. It's basically following the same picture we see with heart failure with a preserved EF in many cases. The treatment here, or I should say, we'll really start with the exams. You have signs of left and right sided heart failure because it usually affects all the chambers of the heart. And so you see pulmonary congestion, systemic congestion, fatigue, again, heart failure type symptoms, edema, JVD, and so on. They probably have, they may have arrhythmias due to conduction abnormalities. Something called a Kussmaul sign, though, is more more unique to this disorder, in that these chambers are so stiff that as venous blood is returning to the heart, it's returning to a high pressure chamber, a very stiff chamber. And so what happens is when we breathe in, remember, we breathe in, we increase volume into the right side of the heart by decreasing our intrathoracic pressure. So what happens is the jugular veins, for example, empty of venous blood more quickly during inspiration, and they empty into the low pressure right atrium. And so usually when we breathe in, blood moves more quickly into the right side of the heart. Now, in Kussmaul sign, what happens is because the heart's so stiff and the pressures are higher, as we breathe in, it doesn't have a real good compliance to accept any more blood. So since it's like a rigid wall, when you breathe in, as the blood tries to rush in due to the decreased intrathoracic pressure, it hits a lot of resistance and high pressure in the heart itself. And so the blood doesn't go anywhere, and actually it can cause an increase in the JVD when they breathe in because it's backing up into the higher compliance venous system. So they call that a Kussmaul sign. So you see an increase in the JVD when they breathe in. Now this is not pathognomonic at all. It is characteristic of this particular type of cardiomyopathy. We're going to have other lectures on. You'll see it in pericarditis when there's a stiffening of the layer of tissue around the heart. So you can see that there as well. Chest X-ray, it may or may not be very diagnostic in this case. You might see some enlargement. ECG may usually non-specific. CT MRI and with a biopsy will help actually rule out something like pericarditis, which is what I was referring to, which can cause those Kussmaul signs. The treatment overall, though, for this is poor. Or so I should say there's a poor prognosis with treatment for this. You got to basically target the underlying cause and hopefully it's effective. So any kind of chelation, for example, for like hemochromatosis, chemotherapy for somebody who has any kind of metastases, and bone marrow transplants for something like amyloidosis, for example. These are things that can be attempted to help conserve not only the heart, obviously, but this is treatment for the patient as a whole for the underlying disorder. For symptoms, salt restriction, reduce some of the fluid. Again, cautious use of diuretics for the reasons mentioned previously for other disorders, and anticoagulation for any type of arrhythmia that may have developed that might have caused blood stasis, as well as maybe an antiarrhythmic if any have developed. So to close out, this is the case question that I want you guys to look over, and we will discuss the answer when I see you guys next. Good luck.